Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of. Today we are discussing the important topic of lupus nephritis in children. It is very important topic. So basically, SLE manifestations presents as lupus nephritis. What is SLE? Systemic lupus erythematosus is chronic autoimmune disorder with multi-organ involvement. Skin, joints, hematological system, heart, lungs, CNS and kidneys. Out of this SLE, the lupus nephritis affects 60% of pediatric SLE patients, and this is severe and more common in children than adults. So this statement is very important. Out of 100 patients, almost 60 patients of SLE lands up into lupus nephritis, and this is more common in pediatric population and more severe. Okay. So this causes major morbidity and mortality in SLE and results from immune complex deposition and complement activation. We will discuss pathogenesis later also. Okay, so if someone asks what is the mechanism of lupus nephritis, what is the pathogenesis behind it? Autoimmune dysregulation, to more precise, loss of immune tolerance, overproduction of autoantibodies against nuclear antigen, and deposition of immune complexes in glomerular capillaries. Basically, what happens? Autoantibody get activated and immune complexes are deposited in glomerular capillaries. Autoantibodies are anti-dsDNA and anti-nuclear antibodies. These two antibodies are culprit of this thing. So, as we discussed also, immune complex deposition in glomerular capillaries and mesenchyma. Complement activation C3, C4, C1q leads to tissue inflammation and damage. Okay, autoantibody attached to glomerular structure and they cause injury. The classification of lupus nephritis, this is the star slide of this whole discussion. So this is WHO classification. We will classify, just see the classification. We have 6 classes. Okay, first, second, third, fourth, fifth, and sixth. Just be with me. This is very easy. Just remember. First is minimal mesenchymal lupus nephritis. So this, the name suggests itself. This is minimal. Second, mesenchymal proliferative. Okay, this is proliferative, mesenchymal proliferative. Third and fourth, if they are focal or if they are diffuse, focal proliferative and diffuse proliferative. Fifth, membranous glomerulonephritis, and sixth is advanced sclerosing lupus nephritis. Okay, so just remember, first is minimal, second is mesenchymal proliferative, third is focal proliferative, fourth is diffuse proliferative, fifth is membranous lupus nephritis, and sixth is advanced sclerosing lupus nephritis. First, just remember these classification and 1 to 6 naming of them. After that, we'll go to clinical features. So, as name suggests, minimal mesenchymal lupus nephritis, no renal finding as expected. Second, mesenchymal proliferative lupus nephritis type 2. This is mild renal disease, minimal minimally active urinary sediment, mild to moderate proteinuria, but may have active serology. This is very important. They may have active serology, mild to moderate proteinuria, never nephrotic range, and minimal active disease. So just remember the key points in this. This is mild to moderate proteinuria, never nephrotic, but may have active serology. So these two lines are very important for type 2 mesenchymal proliferative. If question arises from these sentences, the answer will be mesenchymal proliferative lupus nephritis. Third one is seg focal proliferative lupus nephritis. How we will classify focal proliferative? Less than 50% of glomeruli are involved. Okay, so again, this is very important. This has been sub-classified into active, active and chronic, and chronic. So in this, just remember, less than 50% glomeruli are involved are focal proliferative. If they are involved more than 50%, they are diffuse proliferative. Okay, as of now, we are concerned with type 3 focal proliferative. Let's see clinical features of this disease. Okay, so what they say, this is more active sediment changes, often active serology, increased proteinuria, more than 25% is nephrotic, hypertension may be present, some evolve into class 4 pattern, active lesions require treatment, chronic do not. So this is very important. We'll highlight this statement also. So this is proteinuria 25 more than 25% is nephrotic in type third. Okay, hypertension is present also. Active lesions requires treatment, chronic do not and often active serology. So these three or four statements are very important. Often active serology, proteinuria more than 25% nephrotic, hypertension is present, active lesions requires treatment, chronic do not. So this is focal proliferative lupus nephritis. Just remember highlighted keywords. Okay, now we are moving towards type 4 diffuse proliferative lupus nephritis. As we discussed, more than 50% glomeruli involved are diffuse proliferative. Okay, maybe segmental or global involvement. Like type 3, it has been classified into active, active and chronic. Okay, just see clinical features now. More severe renal involvement because we are progressing towards these staging, so it will be more severe with active sediment, yes, hypertension, heavy proteinuria, frequent nephrotic syndrome, often reduced GFR, serology very active. Active lesions require treatment. Okay, so it is basically similar to this focal proliferative, but it is more severe and more than 50% glomeruli are involved. So we will see active segment, hypertension, heavy proteinuria, nephrotic syndrome like, and GFR is reduced. In this, GFR is reduced. Serology is very active. Active lesions require treatment. Just I'm highlighting this. In this condition, the GFR rate reduced. Okay. Other thing to remember: active sediment, hypertension, heavy nephrotic range proteinuria, and active lesions require treatment. Okay, now we are moving to next membranous lupus nephritis, glomerulonephritis. Okay, this disease causes significant proteinuria, often nephrotic with less active lupus serology. Very important. In this condition, lupus serology is less active. Just remember this. Lupus serology is less active and significant proteinuria of nephrotic range. As we discussed also, nephrotic range proteinuria is never seen in type class 2, but it is from class 3rd, 4th, 5th. Okay, in these conditions, nephrotic range proteinuria increases. And in 2, 3, 4, active serology is seen, but just remember type 4 membranous lupus nephritis, in this condition, the serology is less active and proteinuria is in nephrotic range as all we know. The sixth, advanced sclerosing lupus nephritis. So in this condition, more than 90%, more than 90% glomerular sclerosis. No treatment prevents renal failure. So this is also very much important. No treatment prevents renal failure. So this is the important classification of lupus nephritis, WHO classification. Just go through it once and it is very important in this chapter. Okay, so pathological findings we see their deposition of immunoglobulin, that is IgG, IgM, IgA, and complement C3, C4, C1q, basically immunoglobulin plus complement. If we see this is called full house effect. Okay, this is the keyword for this pathological features, full house staining on immunofluorescence. Okay, so what are the indicator of active disease? Wire loop lesions. Okay, thickened capillary walls due to subendothelial immune depositions. These are wire loop lesions. These are actually active disease indicator. And necrosis and crease formation indicates aggressive disease require urgent intervention. What are the chronic disease indicator are glomerulosclerosis. As we are able to see, this is actually full house effect. Full house effect. Okay, so this is full house. The diagnosis we will do by kidney biopsy. It is essential for histological classification treatment planning. This reveals full house staining pattern as we able to see. Okay. Laboratory markers high anti-dsDNA, active lupus nephritis, and low C3-C4 hypocomplementemia because it gets deposited uh, indicates immune complex activation. Okay. So, lupus nephritis predominantly affects adolescent female. Female to male ratio is 5:1. So, this is more prevalent in female. More prevalence in Asian, Black and Hispanic population. So, Asian population, our population is more involved. Okay. So, what are the treatment guidelines? So, goal of therapy are clinical remission, serological remission, and prevention of progression to CKD or end-stage renal disease. We want normalization of renal function and proteinuria, normalization of anti-dsDNA C3, C4 levels. So, this is very much important. What are the goal of therapies? Then how you will treat? So corticosteroids are first line therapy. Steroids are first line therapy of lupus nephritis. Induction therapy will start with prednisolone 1 to 2 mg per kg per day in divided doses, tapered over 4 to 6 months after achieving remission. Okay, if disease is severe, methylprednisolone high dose 1000 milligram per meter square for rapid immunosuppression. So basically for mild disease prednisolone, for severe disease methylprednisolone. Immunosuppressive therapy, yes, immunosuppressive therapy are used like cyclophosphamide and NMF. The doses are 500 to 1000 milligram per meter square for 6 months and MMF 600 milligram per meter square twice daily. Okay, so this is preferred in black patient. I don't know what they want to say, but this is like that. Maintenance phase, MMF or azathioprine, they are preferred over cyclophosphamide. Azathioprine are used in class 1 and class 2 lupus nephritis. Are there any alternative adjunctive therapies? Yes, in refractory cases, rituximab, that is anti-CD20 monoclonal antibodies, are used for resistant cases. Plasmapheresis. What are the indication of plasmapheresis in lupus nephritis? These are thrombocytopenic purpura, that is TTP, and ANCA associated disease having indication of plasmapheresis. Are there any new drugs which are been introduced? Yes, this is very important. This is belimumab, B cell inhibitor. This is very important. This is FDA approved for SLE but role in lupus nephritis under investigation. But just remember this drug, this is very much upcoming potential thing. This is belimumab. Okay. So, okay. Other therapies are like hydroxychloroquine used in SLE patient for extra-renal symptoms and renal remission maintenance, well tolerated and low side effect profile. So, for extra-renal symptoms, hydroxychloroquine is being used. Okay, ACE inhibitors and ARB for proteinuria and slow renal progression. Supportive care, obviously, we have to give like infection prophylaxis, osteoporosis screening, fertility counseling. Okay, because high dose of cyclophosphamide, more than 20 gram, produced infertility. Okay, so survival, in terms of survival, 10-year non-ESRD survivability is 80%, and highest risk for end-stage renal disease in type 4 lupus nephritis, poor renal function at presentation, persistent nephrotic range, proteinuria. Okay, long-term risk, it might get relapsed, early intervention for flares, side effect of chronic immunosuppressive therapy, all we know, infection, malignancy risk, infertility in cyclophosphamide as we discussed just now. Steroid associated complications can occur, so this is actually important thing. Okay, so just see the summary of treatment. So corticosteroids are used. Corticosteroids are used in mild cases. Low dose prednisone is used. In moderate or severe cases, high dose methylprednisolone is used. Okay, immunosuppressant azathioprine in mild cases, cyclophosphamide and MMF in moderate or severe cases. Maintenance therapy, we can use hydroxychloroquine in mild cases, MMF azathioprine in moderate and severe. And adjunctive therapy, ACE inhibitors, ARB we can use. So this was it for lupus nephritis. This is very important topic for clinical practice, for exam, and for the upcoming advances. Just go through this Muconium ileus. We'll discuss some another topic of this amazing series. Till then, do share, like, and